Good evening and welcome to the 8th webinar of the BASH webinar series. My name is Fayaz Ahmed and I am a consultant neurologist in Hull and East Yorkshire or Yorkshire University Teaching Hospitals in the NHS Trust. And I'm also the educational officer for the British Association for the Study of Headache. I would like to thank the panelists who have given their time to come and talk on this webinar. I'd like to thank the BASH Council, the chair of the BASH, Mark Wetherill, and all the council members who have kindly helped me to organize these webinars. I would like to thank the industry partners, and I would like to share my screen here. We have had the unrestricted educational grant from Allergan, Teva, Lilly, and Lundbeck. They would help to organize these webinars. They are all CME approved, and you can see the code on your screen. Each webinar is approved for 2 hours. And if you attend all the webinars of 2021, you'll get 24 external CME points. They are also available on the BASH YouTube channel, which you can see the link at the very bottom. All these webinars you'll be able to see in this link. So do subscribe to the BASH YouTube channel. It's quite safe. I think some people asked me about the safety of it. So since January, we had, let me just show you, quite a few topics covered. We started with history taking and red flags, followed by secondary headache. Then we focused on migraine, pathophysiology, acute and preventive treatments. We had a bit of cluster headache diagnosis and pathophysiology in May, and then we covered women and migraines. And giving a little break to migraines, we had idiopathic intracranial hypertension in July. Today's topic is childhood headaches. And we have got 3 excellent speakers. We have Kay Kennis, a general practitioner in Bradford. Ishaq Abu Arafe, who's a pediatric neurologist with interest in migraine. And Prab Prabhakar from the Great Ormond Street Hospital in London. They will all be talking about childhood headaches of different types and how to make a diagnosis and manage. The next webinar in September would be on the advances in migraine therapy. So basically, we're going to cover the CGRP, which is a fairly popular topic these days with the new CGRP antibodies, monoclonal antibodies coming. So Masood Ashina, who's currently the president of the International Headache Society, would be talking about the novel targets in migraine therapy and what future holds for migraine. And Jan Hoffman would be covering the CGRP and research. Okay, so without any further input to it, I would like to invite Kay Kennis, who's a general practitioner in Bradford. Now, as adult neurologists, we see a lot of migraines. I mean, I do see some adolescents with migraines. I have no idea how to make a diagnosis of a headache disorder in a 5 or a 6-year-old or even less than that. And I find it very challenging when some parents ask me about their children with the headache. So I'm quite looking forward to learn some skills from these pediatric migrainologists, and they're a very rare breed. I can't think of it, apart from Prab and Ishaq, is there anybody in the UK who's got interest in pediatric migraine? So it's a privilege to have both of them here. But obviously the people would be contacting the general practitioner first, and therefore general practitioner are the only other people who would be seeing childhood migraines. So Kay Kennis would start with her perspective as to what they are seeing in the community and how the general practice or general practitioner would deal or have some tips on their diagnosis, and which one they would be referred to the secondary care. So Kay would be covering that. Then Ishak would be covering on the migraine aspect of it. And then Prab would be able to talk about some cluster and rare headache disorders in pediatric. Okay, I think you should be able to share your slides now.
Right.
Thank you for coming and welcome.
That's great. Okay, thanks. I don't know if everyone can see these slides and whether you can hear me.
We can hear you and we can
okay. You won't be able to see me yet. It says the host has stopped me sharing my video. I don't know if that's something you can sort out, Fayaz, but otherwise it's fine. If not, don't worry.
Just give me a second.
Okay, no problem. So thanks. Okay, I'll just do that now then. Start my video. Okay. That's fine. Thank you, Fayaz, for that introduction. And thank you to everyone who's joined us this evening and given up your precious evening time. So I'm just going to start with a brief introduction to paediatric headache from the point of view of primary care. Just see if I can move these slides on. There we go. So I'm not going to talk about all the different complex diagnoses of headache which are seen in secondary care. I'm just really going to say a few words about what we see very commonly in primary care. I'm going to talk about the warning signs for children who are brought to see us in primary care that might have something serious going on, because that's obviously really vital that we know about that. And I'm also just going to say a few things about how migraine can present differently in children compared to adults. As Fayaz said, we're in a unique position in primary care, so we see both children and adults with migraine, and it is quite different. And then I'm going to talk about a little bit of basic management, really the things that we should be doing in primary care. I'm not going to talk about complex management of unusual secondary headaches. And I hope I can just give a little bit of practical advice to my primary care colleagues about which medications to use, because that's a bit of a minefield, and any other things that we can do to help. And also discuss who we shouldn't be managing, who we should be referring on to secondary care. And then I've just got a couple of slides about some resources and support that's available for our patients. So why are children brought to see us in primary care with headache? There's really only two main reasons, I think, that children are brought. And one is their parents are worried that they've got meningitis. And the second is their parents are worried that they've got a brain tumour. And obviously, we do need to be really aware of meningitis and not miss that. So a child with a headache, fever, drowsiness, photophobia, rash, neck stiffness or positive Koenig sign will need admission. But actually, after taking a full history and examining the child, it's much more likely that they'll have something much less sinister, like a viral upper respiratory tract infection, otitis media, or gastroenteritis, which very commonly involves the child having quite a bad headache. And then brain tumours, obviously, parents are worried about. We worry about missing those. And we do need to take a full history and examine the child. But in the vast majority of cases, the children who are well with recurrent headaches tend to end up with a diagnosis of migraine once you've unpicked it. So about 3% of preschool children do get migraine. So probably higher percentages than you might expect. And then by the time the children are old enough to be at high school, about 15% prevalence of migraine. Sometimes we do see rarer primary headaches, and we need to know when it's not migraine and when to refer, cluster headache and other things. And we need to know when there may be a serious underlying cause, but that is quite rare. So what warning features do we need to be thinking about? Number one is a child with a headache and balance or coordination problems. That's the most predictive feature of there being a secondary pathology. So a child with headache and balance or coordination problems, you'd want to admit. Similarly, a child with headache and seizures, and that goes without saying, you'd admit that child would probably present to casualty rather than primary care. A child with a headache that can't stop vomiting needs admission to look for secondary causes. And a child with a headache who's drowsy or lethargic, you would admit. But it's also worth mentioning that some secondary headaches can present with more subtle behavioural change. So if the parent says, look, it's just not him, it's just not her, schoolwork's going downhill, memory's not what it used to be, that is something to take really seriously and to refer for further investigation. Sometimes a serious secondary pathology can present with increasing head circumference. Now, we don't routinely measure head circumference after the first year of life, but if a parent does say, look, the child's head's getting larger, that's something to really take seriously. A child who has headaches that are always in the early morning or worse when they lie flat or worse on exertion needs a referral for further investigation because that might indicate a space-occupying lesion. A child with a headache that's getting progressively worse, you would admit. And any child obviously with abnormal neurological signs or papilledema needs admission. It's also worth being aware of the children who are around the age of 12 to 18 who have a headache with delayed or arrested puberty, because that can indicate a pituitary problem or another underlying space-occupying lesion in the brain. I've put a slide on examination. It's really hard for us in primary care at the moment because we are expected to try and speak to our patients on the telephone and bring in only patients that we really have to see. But I do think you do really have to see a child with a headache. You need to look at their gait. You need to look at their eye movements. You need to look in the fundus. If you can't see it or you're not confident, it's absolutely fine to ask the parents to take them to the optician to look properly. It's a free of charge check for the children. And we should be trying to do a blood pressure. Children do get high blood pressure and they can have funny causes for that, such as coarctation of the aorta. But I appreciate sometimes it's tricky to find a paediatric blood pressure cuff. So I've put a slide in here about migraine in children because that is the most common primary cause for headache that we see in primary care in children. And it does present a little bit differently to the way that we're used to seeing migraine in adults present. So first of all, the incidence of migraine in children is equal in boys and girls, whereas after puberty, because of the hormonal changes, and as we know in adults, you see a lot more females with migraine. The other thing is that migraine will often present as abdominal pain in children or be associated with abdominal pain, which is not the case in adults. If the child does have head pain, it's often bilateral or frontal, which is different to the adults who tend to have a unilateral throbbing pain. It's also much shorter duration. In adults, you'd be wary of diagnosing migraine if somebody had a head pain less than 4 hours, but in children, it's often less than 2 hours. If a child is getting unilateral headache, then you need to be alert to the fact this might not be migraine. It may be a trigeminal autonomic cephalgia. So you need to ask about the autonomic features, which I know Dr. Propaker will come on to later. Children often really find it really hard to describe pain, and it can be more helpful to ask their carer about what they do during the headache. So they tend to be quite movement sensitive if they have migraine, and they tend to stop doing their normal activities and have a lie down or go off their food. They can often look pale. They can show sensitivity to noise or light by their actions rather than telling you about it. And sometimes they have a sleep afterwards. If you think they've got migraine, it's also worth digging around for history of infantile colic, travel sickness, periodic limb pain, because these things often go hand in hand with migraine. Sometimes children also have other periodic syndromes, such as cyclical vomiting or paroxysmal vertigo. I won't say any more about those because I think Dr. Abu Arafeh will talk about them later. But just to highlight that if a child does present in primary care with cyclical episodes of vomiting or cyclical episodes of dizziness, just to have your migraine radar on to think, well, could this be one of the childhood periodic syndromes? Because what we don't want is for children to be over-investigated. It's often a family history of migraine. And we often find children are brought at times of change. So they've maybe had a growth spurt, or they've gone on holiday, or they've moved school. And that's when migraine can tend to worsen in children and adults, actually. I've put in a few slides on management. I won't talk about the management of meningitis or gastroenteritis because that's outside the scope of this talk. And most of the time in primary care, if it's an unusual headache, we're going to be referring them. So most of the time when we're managing headache, it is managing migraine. And I think as for adults, it's really important that we make a positive diagnosis and we tell the child and we tell their family that they have this condition called migraine and what that's going to entail. Because very often children are told, oh, don't worry, it's nothing serious. But then the children and family are left a little bit in the dark and as about exactly what is going on. It can be really fulfilling to be able to give the child the positive diagnosis at an early stage and start them on their migraine journey, knowing what's happening to them. We talk to the child about how they can help themselves by eating regularly, drinking plenty, having exercise, etc. And I won't say too much about that because it's what we've already spoken about in previous webinars, and it's the same in adults. We need to know how to prescribe appropriately, and I've got a slide on that coming up next. We often can help the child and family by devising a migraine care plan, and I'll talk a little bit about that. We can direct them to some good information and support, and I've got some slides on that at the end. And if we're not winning, we need to know to refer them. So prescribing can be tricky in primary care because of the different medications that are licensed and unlicensed. We know to avoid aspirin in children because of Ray's syndrome, and we know to avoid opiates because they're not good for migraine, they're addictive and have lots of side effects. It's very important that we do prescribe sufficient doses of the acute and preventive medications, and we tell children that they should take it straight away rather than waiting for the headache to sort of set in when it doesn't work anymore. I've done a little table here, which is a crib sheet for people, because I think certainly it's taken me a long time in general practice to try and figure out what's licensed for children and what's not. And there's no easy reference guide for this. When we're treating migraine, we usually start with paracetamol or ibuprofen, which in primary care, we're very familiar with prescribing. It's easy, it's available in liquid forms, and it's available for kids right from babies onwards. If the paracetamol and ibuprofen isn't sufficient, then I'd normally go to metoclopramide next. Again, it's available in a liquid format and it's easy to prescribe from very young children onwards. If the combination of the metoclopramide plus the simple analgesic isn't enough, the next step is sumatriptan really, or zolmitriptan. Sumatriptan's tricky because under the age of 6, you can't give it it's not licensed to give. And then after the age of 6, you could give it in oral formulations, but the dose is 25 milligrams is just not available. So really, when I add in sumatriptan, I usually add in the nasal spray, which has better evidence of efficacy anyway. So although it's not licensed until the child is 12, I have frequently given it to younger children. Usually I would just speak to one of the consultants first and check they were happy with it. So you just need to prescribe really according to what you feel comfortable with, but we do commonly use it. It's not unlicensed because of any dangers, it's just simply because when the trials were done, there was quite a high placebo effect, so it's safe. And then if we need to use migraine preventive therapy, there's 3 options that are licensed, and that's the propranolol, pazotafen and topiramate. And those are things that I think if you feel comfortable with, we can and should be using in primary care before we refer on. Apart from prescribing medication, it can be very helpful to write a little bit of a health care plan for the patients, for the children and their families and their schools. And sometimes, although time's really precious in primary care and it's difficult for us to sometimes sort of write letters and things, I I think that a child who's struggling with migraine at school and maybe missing education or starting to refuse to go to school or being stigmatized, I think it's a really important time to get out your I was going to say pen and paper, but that's old fashioned, to get on the computer and type a letter and send it off to school. And there are quite a few reasonable adjustments that the schools can make. And I've done this as a crib sheet because sometimes it's hard to think of advice that you can give to the school. So they can offer the child some support to catch up on any missed education. They can ensure they have instant access to their medication. They can make sure they have access to food and drinks breaks. They have access to a dark, quiet room if that's needed. Sometimes they might need intermittent breaks from intensive work and not to spend prolonged time on the computer. Sometimes they might need their seat changed within the classroom so there's more natural lighting and good ventilation. Deadlines can be extended, separate examination rooms can be provided, and PE can be changed to low impact activities rather than the high impact games if the child's getting headache with exertion. And it's also important to just make the school aware that this child does have a genuine medical condition. They're not school refusing, and to get rid of some of that stigma. We know that kids with migraine miss a lot of school, but also they turn up to school with migraines and then they're not learning as effectively when they have the migraine. So the more we can do for them, the better. Sometimes we do have to refer to secondary care, and that's if we're worried about a secondary headache, if we know they've got migraine, but we can't get them to respond to medication, or if we're not certain about what the diagnosis is. Just a couple of slides on resources that we can direct our children to and their families. The Migraine Trust has some good resources. So if you go onto the Living with Migraine tab and then click on reducing the impact of migraine, then you can get a menu here for managing migraine in education. And there's a really good Help in Schools toolkit and Help in Higher Education toolkit. And this is all just about to be updated this month, I think. There's also a really good migraine in schools policy from the RCGP, which was written by my colleague, David Kernick. And often I'll print this out for families for them to read through and then take into school and discuss. If there are any primary care clinicians wanting a little bit more information, there's a fantastic podcast, which is done by my colleagues, Katie Munro and Jessica Briscoe at the National Migraine Centre. This is well worth a listen. So in summary, headache in children is really common. It is usually migraine or part of a mild viral illness, but we have to be aware of serious causes. Migraine doesn't always present as headache in children, so we need to know that. And it is even more important to treat migraine properly in children compared to adults, because undertreatment can really impact on their learning and psychological and social development.
Thanks very much, Kay. That sets the platform for the talk from the pediatric migrainologist. I forgot to mention that we have worked together with Kay for quite a while. Kay was in the NICE appraisal on the CG 150 guidelines on headache disorders. And also Kay is a trustee of the Migraine Trust. So she has done a lot for the headache community. Okay, so let's move on to migraine in children and adolescents. Ishaq Abu Arafe, who was also in the NICE CG 150 guidance that developed by the NICE about 6-7 years ago. And he's a consultant pediatrician and particular interest in migraine and headaches. He is also the chair of the pediatric section of the International Headache Society. And he has had lots of publications, chapters, and books to his name. Ishaq is going to talk about migraine in essence. Ishaq?
Well, thank you very much, Professor Ahmed, for the nice introduction. And thanks for Kay for setting the scene for me. Makes my presentation much easier and my task easier. What I will be, My talk will cover a few areas on childhood migraine. First, look at the classification of headache disorders, look at the epidemiology. I will talk about clinical representation and which is specific for children and adolescents, and we'll talk about treatment. Classification of headache disorders as has been published many times, and most recently in 2018 by the International Classification of Headache Disorders, International Headache Society, are classified through 3 levels. The first level is on etiology. So there is a group of headache disorders which called primary, mainly migraine, tension type headache, and trigeminal autonomic cephalalgias. And the second big group are the secondary headaches. And from a children's point of view, the common causes of secondary headaches are post-traumatic, persistent headache, medication overuse, and less often we see, but very important, are brain tumors and idiopathic intracranial hypertension. There are some other neuralgias which are classified under others. The second level of a classification is the clinical features. And from migraine, it will be classified into several subtypes, like migraine without aura, which is the most common subtype, followed by migraine with aura. And then from pediatrics point of view, we will talk about the related syndromes. The third level of classification is dependent on the frequency and the duration of attacks. And from migraine point of view, if a migraine occurs on more than 15 days per month, it will be called chronic migraine. If it is less than 15 days per month, it would be called episodic migraine. The number 15 is not magic, but it is very helpful when we talk about chronic migraine because it has specific issues in relation to comorbidities and treatment. Migraine, as I said, would be classified into several areas, and the areas of interest, which I will be covering in this presentation, are migraine without aura, migraine with aura and hemiplegic migraine, and the episodic syndromes that are related to migraine. From epidemiology point of view, we know that headache is very common in adults, more in women than in men. In children, it's the same thing. Headache is very common. About 60% of children in all prevalence and epidemiological studies across the world has shown to be affected by headache. Again, girls are more likely to be affected than boys. The same thing in migraine. Migraine is common in adults and more in women than in men. Typically, the same thing we see in children. 7 to 8% of children worldwide are affected by migraine. Girls are more likely to be affected than boys, especially those over the age of 12 or 14 years. Under the age of 12, probably boys are equally affected as girls. That's what we see in population-based studies. But in clinical services, we see probably a different picture. In a specialist clinic, chronic daily headache or patients with chronic daily headaches presents quite often, and more than 1/3 of the patients which I see in the clinic fulfill that criteria. About 1/4 have migraine without aura, and about 20% will have classified or unclassified or mixed types of headaches. We don't see tension type headaches in except occasionally in secondary or tertiary care because they will usually be dealt with in primary care. If you look specifically at the children with chronic daily headaches, you will find almost half of them fulfill the criteria for the diagnosis of a chronic migraine. About 1/3 have medication overuse headaches, and most of those with medication overuse headaches are probably have migraine as well. Now, the clinical assessment of a child with migraine, or before you make a diagnosis of migraine, the child with headache, has been eloquently illustrated by Kay. So I will not go into too much details, but what I would like to say is the clinical diagnosis relies mainly on taking a very good history. And if that history could not give you a diagnosis, maybe we should do it again and again. And when patients are referred to secondary care or tertiary care, the only thing tertiary or secondary care doctors do is to take a full clinical history. When you take a history of a headache, it's important to look at the duration of the disease, how long the headache's been going on, the frequency of the attacks, the duration of attacks, the site of maximum pain, the quality of the pain, and the severity of the pain. We look at the trigger factors, associated symptoms, and relieving factors. And also you need to look at the state of health between attacks. Examination should include measurement of weight, height, and the blood pressure, as has been mentioned earlier. And then we need general examination and neurological examination, including inspection of the optic discs. Having all this information being gathered from history and examination, it might be, in most of the instances, possible to make a classification, whether it's primary or secondary. And also, it will be possible to make a diagnosis of the type of headaches. Sometimes the information will not be complete until we do a prospective headache diaries. And a diary like this one would be very useful in several ways. It helps us to understand the pattern of the disease with the frequency and the duration, whether it is episodic or whether it is a chronic in terms of migraine. But also it can give us an indication of the phases of the attack of migraine, starting from the premonitory symptoms. In some patients, they are very clear. In other patients, they are subtle and not prominent. These symptoms occur about 24 to 48 hours before the onset of the headache. They consist of craving for food, yawning, tiredness, change in mood, or a change or heightened perception. They become very alert. And then followed by aura in some 10 to 15 or 20% of patients, which usually visual. Then the headache phase, which consists of the increasing severity of the pain building up within half an hour or an hour to reach maximum intensity, associated with nausea, vomiting, intolerance to light and noise, and so forth. And then that would be followed by the recovery phase and their complete resolution. Once you have done all these with the help of the history, physical examination, the diaries, and assessment of the patterns, you might identify some red flags which necessitate the need for further investigations and assessment. Kay has highlighted the issues, and they fall mainly under features of raised intracranial pressures, features of cerebellar dysfunction, new neurological deficits, or recent personality change, and also if there are any features to suggest Chiari malformation. And Chiari malformation headache is different than migraine. They are short and they can be induced by Valsalva maneuver. Once the diagnosis of migraine is done, it has to be done in a positive way, as Kay has already mentioned, and you have to tell the parents this is migraine and we don't think of anything else based on the following reasons. And then you need to assess the impact of the migraine on the child and the quality of their health, life, and education. And the best way to do it is by using the BED-MIDAS score, which looks at the number of days the child has been off school, the number of days where the child has been sent to home from school because of the headaches, or when the child was not performing or was performing below 50% of his or her abilities. This can be helpful to assess and monitor the progress of the disease. Looking at migraine without aura, which affects 80% of children with migraine, this is the criteria for the diagnosis. It's similar to that to those in adults, but the duration of attacks, as has been earlier mentioned, is less. The minimum is about 2 hours rather than 4 hours in adults. But still, you have to have the other features, associated features, and the quality of the pain to make the diagnosis. In some children, there is a clear triggers, but only in the minority of the children. About 1/3 of the children will have a clear trigger for the migraine, like stress, missing a meal, or missing a sleep. Some children can't describe pain, and we have to accept that. The severity of the pain is judged by the effect of the pain on the child activities. So it is mild if it does not interfere with activities. It is moderate if it stops some, but not all activities. And it is severe if it stops all activities. Cranial autonomic features can be present in up to 50% of patients, and usually they are bilateral. As the child grows and the brain develops and the gray matter matures, the perception and the expression of symptoms become
I think we lost you, Ishaq. Okay, I'll just send him a message if you bear with us for a minute. I'm so sorry. I think we probably have lost Ishaq somewhere. I've just let him know that he may have lost the connection. So bear with us for a couple of minutes. Hopefully we should get back again to his slides.
Fayaz, there was one question in the, maybe we can just do that while Ishaq is joining us.
Yeah, I think you might want to answer that question. I mean, you may have to tell the question as well.
Yeah, so it was from Mubashir asking about metoclopropamide and the restrictions in terms of side effects, extrapyramidal especially in children. I don't know what your experience has been, Kay, in terms of primary care with using metoclopropamide. Maybe you can.
Yeah, I think it is really difficult, and we do worry about giving any medication to children. So it's not something we do lightly. I think the difficulty is you've got a child who's got a really severe medical condition that's affecting them. You would try simple things first, the paracetamol and the ibuprofen, but sometimes they do need an antiemetic. And the advantage of the metoclopramide over something like cyclizine is it's prokinetic. So it does work a lot better in migraine. I mean, I have prescribed it in children, and I do have the conversation with the parents to say that there are potential side effects, but it is something I'm still happy to prescribe. Don't know what you do in secondary care.
Yeah, I think, oh, good. Ishaq has just joined as well. He's getting the slides back, Ishaq.
Yeah, I'm so sorry for that. I think I ran out of the batteries of the laptop. Am I able to continue? Or,
yes, please do. Yeah.
Absolutely. We haven't lost any audience, so people know that these technical things do happen. So
I'm so sorry. Yeah. So what I was saying is that the duration of attack is shorter in children than in adults, and like as you can see, it increases in a duration with age. Also, the frequency of attacks of migraine increases in younger children, and it reaches a peak in late adolescence. Also, the site of maximum pain, it changes. 70 to 80% of children under the age of 10 describe the headache occurring on the forehead, but that drops to about 50 to 60% by late teenage. And if you look at the bottom of the slide, the unilateral pain or unilateral headache is not common at all in younger children, less than 20% at the age of 10, but it increased to 30, 35% by the age of 17 or 18. Also associated symptoms, it change with the age, and you can see this lightheadedness is very rare in kids because they don't understand probably the concept, or they don't have the vocabulary to describe it, but it increases gradually into the teen age. The same thing in vomiting is very common in younger children, affecting 50 to 60% of kids, and it becomes less prominent. Only 1/3 of adolescents will have vomiting. Nausea, photophobia, and phonophobia are common, and they are quite often unchanged. Migraine with aura in the children is about 15 to 20% of kids. The aura is mainly visual, as in adults, and some children have difficulty in describing their visual experiences, and giving them the chance to draw it, they can give very good, sometimes lively description of the aura itself, and sometimes of the pain as well. Visual aura is the most common. 60% of the times starts before the onset of headaches. 20% of the times it starts with or after the headache. In 80% of the children, visual aura is the only aura during that attack, but in 20%, there are other associated auras such as somatosensory, language disorder, or weakness with motor disorder. And 60% of the times, the aura is bilateral, and in 70% of the times, the aura is that of moving objects. I wanted to think about this girl who is a 10-year-old, presents with episodes during which she screams, fearful. She sees her mother's body shrinks in size, but her mother's face grows larger. And that gives her a fright associated with visual other disturbances. She hides her face with her hands, and after a few minutes, she starts to have the headache, and the headache reach severity within 30 minutes, and she feels nauseated and vomit. The syndrome of Alice in Wonderland has been described in adolescents, but also sometimes in adults. And the question is that visual aura, or is that a distorted perception associated with migraine? Most people will think it is not an aura, but it is a distorted perception. Nevertheless, it is a syndrome which we need to be aware of, and we should need to recognize and deal with. Hemiplegic migraine is rare, but a very important migraine with motor aura. It is associated with weakness on one side during the attack of migraine, and it can either be familial, where it runs in families, or sporadic. When it is familial, several gene mutations have been identified. The diagnosis of hemiplegic migraine should be taken with very much caution, especially on first or second attack, and most of the kids will undergo MRI and MRA. Chronic migraine is another issue which I'd like to talk about. It's, as we defined it earlier, a child who has headaches on at least 15 days per month for at least 3 consecutive months. 8 of the 15 days are those of typical of migraine, either migraine with aura or without aura, or migraine which is in the view of the patient, or headache in the view of the patient and the family is migraine. Chronic migraine is common. About 1 to 2% of adolescents suffer from chronic migraine, some of them with medication overuse, some of them are not. Similar to what has been described in adults, probably slightly less. Chronic migraine has predisposition for people or children who usually overweight or have other chronic pain disorders, or some psychiatric comorbidity, such as depression and anxiety. The relationship between a chronic migraine and psychiatric comorbidity are probably bidirectional. In a way, children who are prone for anxiety and depression might have a higher risk of chronic migraine, and the other way around, patients with chronic migraine have higher risk for developing anxiety and mood disorders. The quality of life of children in general worsen with the increased frequency of headache, as you can see when measured by BID-MIDAS, or Beats Quality of Life 4 version. The score increases with the increased frequency. And this is why it's not surprisingly to see that chronic migraine is associated with high impact on children's life. Syndromes related to migraine, which have been typical for childhood syndromes, which we have reviewed recently in a paper for Nature Reviews in Neurology. And I'd like to mention 5 syndromes, but very briefly, because Kay has already talked about some of them: infantile colic, benign paroxysmal vertigo, torticollis, cyclical vomiting, and abdominal migraine. I want you to think about a baby who is under 3 months of age, who's been having episodes of crying at least 3 hours a day for at least 3 days a week for at least 3 weeks. The child is completely well and healthy otherwise, feeds well and grows well, and develops well. And we think that the pain is because of a colic, but actually we have no way to be certain of that, and we assume that the pain is coming from the abdomen. These kids, they followed up prospectively, and as you can see in the first study by Silanpo and Saranin in Finland, 23% of infants with colic grow up to have migraine as adolescents, compared to only 11% to babies without infantile colics. Also, in the bottom, you see retrospective studies. Adolescents with migraine are more likely to have had infantile colic as babies than adolescents without migraine. And again, mothers with migraine are more likely, or 2.5 times more likely, to have babies with infantile colic than mothers who do not have migraine. Benign paroxysmal torticollis, it's when we see it in children under the age of 2, where the child suddenly feels unwell, looks pale, cries, holds the head to one side. There are no other symptoms or signs, and there is no neurological deficits, no loss of consciousness. It lasts for a couple of days, and then it is recurring every 2 to 3 months. The children will have less and less attacks by the age of 3 years, and they resolve completely by the age of 5. And they may be followed by headache or by migraine or cyclical vomiting syndrome, as you can see in this follow-up study. Children with paroxysmal vertigo, again, they present between the age of 2 to 5. They present with sudden episodes of panic or fear. They are unsteady. They hold on something, the mother's leg or the furniture, or they lie on the floor in panic. They don't lose consciousness. They might have nystagmus for the observed eye, and once they recover completely as if nothing happened. All investigations will be normal. Some of them will have family history of familial hemiplegic migraine, and some of them will have family history of mutation on the CACNA1 alpha gene and the PRRT2 gene. Cyclical vomiting syndrome is a very well-known syndrome which has been described for many years. It is characterized by attacks which can be described as stereotypical because they are exactly a replica of each other, and quite often with a predictable periodicity. Parents can tell when the next attack is going to happen, and they put it on the calendar, and quite often they are quite right within a couple of days. There is no known trigger factors, but the trigger factors are similar to those in migraine. And between attacks, the child is completely well and healthy. Children grow up to have migraine, as you can see in the follow-up study on the right-hand side of the slide. Abdominal migraine is also another condition, affects usually older children between 8 to 12, and more girls than boys, with a prevalence of about 2 to 4%. It is characterized with the severe abdominal pain, dull in nature, very umbilical in location, associated with vasomotor change, pallor or flushing of the face, and associated with anorexia, nausea, and vomiting. Between attacks, the child is completely well. Quite often, you need to investigate these kids to exclude other conditions. Both cyclical vomiting syndrome and abdominal migraine share quite a lot of characteristic with migraine, especially with the phases of the attack and also with the trigger factors, associated symptoms, and also the coexistence of the three conditions together in one patient or in one family. I want to talk quickly about the treatment, which I'm sure that it is of interest to all of us here. But I'd like to say there are common management plans for all types of primary headaches, including migraine, tension type headaches, or any other one. And it starts with reassurance in making a positive diagnosis of migraine, as Kay has mentioned very well early on. It has to follow the biopsychosocial model, both in presentation, but also in management. We need to educate the child and parents on the natural course of the disease, which involves remissions and relapses, and to agree strategy for treatment and deal with expectations that we can't cure the disease, but we can help the child in managing his or her life. Non-pharmacological approach is mainly useful in acute attacks to avoid aggravating factors such as light or noise, give the child the chance to rest or to sleep, and to give and allow parents to take the role of a supportive carer rather than a panicky carer. And they might need support from schoolwork or from school staff, teachers, and from creating an environment which is conducive to early or quick recovery. Give the child a chance to take fluids. The pharmacological approach is important and is crucial in the management of acute attacks. And it is very important to know that to make the child understand that the earlier they treat, the more likely to be successful. And they have to use the most appropriate drug, the most appropriate dose, in the most appropriate formulation and route of administration. Paracetamol and ibuprofen continue to be the cornerstone. They are very widely used. They are effective. They have excellent safety profile. Sumatriptan is the only triptan which has been shown in double-blind placebo-controlled trials to be effective in children, especially in the nasal formulation. Although zolmitriptan and rizatriptan have also there are evidence for their efficacy. Sumatriptan added naproxen has also been also shown to be superior than placebo in double-blind placebo-controlled trials. Very recently, the American Academy of Neurology published their practice guidelines on the management of migraine in children and looked at the acute treatment. In general, it is accepted that the first line of treatment is to use simple analgesia, paracetamol or ibuprofen. Paracetamol should be used in a good dose, 20 milligrams per kilo in the first dose, followed by 10 to 15 milligrams per kilo as required. Ibuprofen, again, 7.5 to 10 milligrams per kilo. If that fails, you can try sumatriptan nasal spray, 10 milligrams, but you can't use more than 2 doses in one day, and preferably not to use it on more than 2 days per week. The third line of treatment is to use a combination sumatriptan with naproxen. It's not available here to us in Britain, but we can use sumatriptan nasal spray with ibuprofen taken at the same time, or a tablet with ibuprofen, or we can use the zolmitriptan tablets as melt or as a nasal spray. Other options for acute treatment, we might need to give antiemetics, and I don't have any strong preference, but you can use the drug which you feel most comfortable with and that we have most experience with. There are still unmet needs for acute treatment of migraine in children. In the pipeline, lasmiditan is coming along. It is undergoing trials at the moment in children, and CGRP antagonists are on the horizon. We are already started recruiting for the trials on the use of lasmiditan in children. There's 2 studies. The first one is double blind. The second one is open label. And if you have patients you would like to enroll in this study, you can speak to your nearest center, and I'm sure they will be grateful for you. From prevention point of view, non-pharmacological strategies are important, and as Kay has mentioned, we need to give a good education and maybe accessing resources online. and give advice on regular meals, regular sleep, regular exercise, good amount of rest, and good hydration, and obviously on screen time. When to consider preventative treatment, obviously it is a joint decision between the clinician, the parents, and the child, and it depends on several factors. One of them, the frequency of the attacks, the severity of the attacks, the successful or unsuccessful acute treatment, and the impact of the disease on the child's education, work, and family life. Once you started the treatment, it's very important to emphasize the importance of taking it regularly. And it is also important not to judge the treatment whether it was successful or unsuccessful until you have used it in optimum dose for at least 4 to 6 weeks. If it is successful, you don't want to use it forever, but every 6 months you can review the need for the treatment and whether you can stop it. If you stopped it and the child has relapsed, then you can restart another course of a treatment. There are 2 guidelines telling us how to treat children with the preventative treatment. The NICE guideline was first published 2012 and updated in 2015, and the American Academy of Neurology practice guideline published in 2019. NICE in 2015 looked at the evidence available at that time and gave advice that if preventative treatment is needed, to offer propranolol. If that fails, we can consider topiramate or amitriptyline. 2 years later, in 2017, the CHAMP study was published, which looked at amitriptyline and topiramate against placebo. The results of this study was very frustrating because the placebo response was very high, between 66 to 71%, which mitigated any benefit from amitriptyline or topiramate and made the results to look as if neither of the drugs are superior to placebo. The American Academy of Neurology took awareness of that, and in their guidance, they will say, well, there's no drug which has been shown to be more or superior to placebo. So when discussing with the child and the parents, we need to acknowledge that and to engage them in decision making, and we need to tell them that amitriptyline with CBT has the only treatment which has shown to be effective, but we can discuss propranolol, we can discuss topiramate and amitriptyline, and we can be pragmatic in how to use them. So there is a very big gap, and there is a lot of unmet needs for prevention of migraine in children. Some of us are using now greater occipital nerve block in teenagers and in adolescents for the management of a chronic migraine. It was shown to make subjective improvement in about 2/3 of children with a chronic migraine in open studies. Other potential treatment is botulinum toxin. It has been shown to be effective in adults in improving quality of life. In children, we have only open studies. It shows to improve the quality of life despite the fact that it did not reduce the number of days much. So it maybe reduce the severity of the pain, allow the child to function better. There are other options which we don't have any evidence for their benefit in children, such as in neuromodulation, whether it's transcranial magnetic stimulation or peripheral nerve stimulation, supraorbital branch of trigeminal nerve or the vagus nerve. On the horizon is CGRP monoclonal antibodies, and there are 4 drugs have been evaluated recently, and CGRP antagonists, and 3 drugs have already been studied, and they have shown good response in children. The monoclonal antibodies have all shown to be superior than placebo in reducing the number of or monthly migraine days, in reducing the frequency over 50%, and reducing the need for acute medications. We are now running trials on ianalumab in the prevention of migraine in children. It consists of 2 phases. The first phase is double-blind placebo-controlled trial, followed by an open extension study. So again, if you have patients who fulfill the criteria and would like to take part, you can refer them to your nearest participating center. In summary, migraine is common. Chronic migraine is also common in adolescents. Migraine in children is largely similar to that in adults, but with a specific presentation, which are different. Treatment of acute migraine attacks is still unsatisfactory, unfortunately, and as well as preventative treatment. So clinical trials are ongoing. I thank you for your patience, and I'm very, very sorry for the interruption and for the technical hitch, and I'll stop here. Thank you very much.
Thank you very much, Ishaq. That was really good. I'm sure we would come back to you with the questions in the panel discussion. So let's move on, and I would like to invite Prab, who works in the Mecca of Children Hospital, which is Great Ormond Street Hospital. Gosh, oh gosh. And whenever I find anybody contacting me about headaches in young, very small children, I have two names in my mind, Ishaq and Prab. There's nobody else. Prab has been a good friend. He's been a very good contributor in BASH education sessions, have always come to Hull to do the biennial pilgrimage that people come to Hull for headache meetings. I hope that we resume it soon. So Prab is going to talk about some rare headache disorders and how to actually recognize them, because it's very difficult to recognize them, because as Ishaq said, history taking is crucial, but how do we extract the history from a child? So Prab is going to talk about that. Prab?
Thank you. Good evening, everyone, and thank you, Fayaz, for the very kind introduction, and my colleagues who've just spoken ahead of me. Always delighted to listen to them. I always learn new things every time. So thank you. So when we were planning this talk, we thought it would be a good idea that Kay went first from her general pediatric practitioner point of view, and then Ishaq, who also will take referrals from general practitioners as a pediatrician with an interest in headache. And by the way, we have also called him the grandfather of children's headache in the UK. And as you can see, he has already kind of written 3 books on it. So I'm in a very privileged position, because by the time children are referred to me, they've had the works. They usually are, have a primary headache disorders, because most of the secondary headache disorders, Kay has already sorted out their sinusitis, referred to the pediatricians to treat the meningitis and whatnot. So I think most of them are taken care of. So we tend to end up with these primary headache disorders. And this is the only slide I always say to my trainees, actually, you need to know. Very easy, primary headache disorders. You've got only 3 headaches to think about. Migraine, which Ishaq has very eloquently talked about, because if the child presents to you with a problem headache, it's 9 out of 10 times it is going to be migraine. Tension type headache is a very featureless headache. It does happen in children, but if the children are present to you with a problem headache, then it's almost always a migraine. The trigeminal autonomic cephalalgias, which you're going to talk about today, there are 2 major ones. One is a cluster headache, and the other one is proximal hemicrania. Now, they are very rare. So in some sense, the talk, you might ask, why is it? And I think before we go down there, this is usually a mnemonic that we use to teach pediatricians and others in terms of headache disorders in our chat course from the BPNA, Liquid 4. It's a useful mnemonic to just kind of get a very good history, very quick history from a child. I know GPs especially now have about 7 minutes to take a history over the telephone. So a usual mnemonic to just get the history out of the way. So really, why do we have this separate topic? And we'll cover what's cluster headache, what causes it, and what are the features in children, and so on, and why is it different from migraine. So why a separate talk? So I did a PubMed search today. I put in the terms cluster headache, and I had about 577 hits. Okay, and then I added cluster headache and children, and that went down to 263. And then I looked at the results and just looked at only cluster headaches because it came up with everything else. And there were only about 24 articles on cluster headache and children on PubMed. Okay, and you look at the articles again, and there were only 8 of these were actually case series. And 2 of them were from our institution. And so you can see how very little there is in the literature about cluster headache, especially in children. So it's very rare, but it's actually quite important because when you talk to adults who have had children who have had cluster headaches, and especially women, they say that it's worse than childbirth. You know, that's how you know, very bad the pain is. And of course, you've had adults who have been driven to suicide because of these headaches. So in children, we talk about the morbidity, slightly a bit different, but it can come with a huge morbidity. And it can be a bit difficult to recognize compared to migraine, but I can give you a very quick handy tip to do it. Just remember this and this, and we'll talk about it later in the talk. And I think treatment is different, so we really do not need to know about this. So what are trigeminal autonomic cephalalgias? It's a primary headache disorder. There are a few things. Number one, it's a side-locked headache. So it just sticks to one side. It's either the left or the right. That's it. It doesn't cross the midline. So remember that. And that happens in children, okay? Just not in adults, in children. And one of the important things to remember is actually in children, if you were paying attention to what Ishaq was saying earlier, a lot of the children get bifrontal headache. So the migraine, which is the most common primary headache disorder, which will present to you, has got a bifrontal distribution. Unlike a trigeminal autonomic cephalalgia, where it is a very much a unilateral side-locked headache. So side-locking, a key point in terms of trigeminal autonomic cephalalgias, especially cluster headaches. And then the distribution of the pain, it's in the ophthalmic branch of the trigeminal nerve. So the pain is around the eye, perhaps in the temples. Again, as you will see from the study we done at Great Ormond Street, it can actually be frontal as well. And of course, the autonomic symptoms. So the pain, it's orbital temporal, it's side-locked, it's very severe. In the older teenagers, they will describe it as boring or drilling in nature. It can last for a few seconds to several minutes. The frequency can be variable. As I will tell you, there are various types of TACs, and you have autonomic features, and it is incredibly incapacitating. So what are the autonomic features? It's all ipsilateral to the pain. So same side where your headache or is, you have this eye redness, eye watering, all of the same side. Nasal congestion or a nose watering, a bit of eyelid, it looks a bit puffy, they got eyelid edema, they got forehead or facial sweating, and sometimes a bit of flushing. The pupils go a bit small, the eyelids droop, and sometimes you have this flushing that goes with the sweating, and you have this fullness in the ear, all on the same side of the attacks. So what are the different types of TACs? You have cluster headache and paroxysmal hemicrania, which are the two common ones that we see, they are rare, but among the rarities, these are the two actually we see in pediatric practice. There is another very short trigeminal autonomic cephalalgia, which is the short-lasting unilateral neuralgiform headache attacks, of which there is SUNCT, which has got conjunctival tearing and redness, and SUNA, which has got the autonomic features. I would recommend that if you haven't done, please go look at, just Google ICHD3, which stands for International Classification of Headache Disorders, the third version. Just Google it. This is the top search. You will come up. Excellent resource to learn about and know the criteria for all these various primary headache disorders conditions. Hemicrania continua is one of the chronic forms of TACs, and it's a kind of a cousin for the paroxysmal hemicrania, which is an episodic fracture of the headache, and hemicrania continua is a chronic form of that type of that headache. So I won't bore you with the details. I just put all this criteria in there. I just want you to pay attention to the things in red. Basically, you've got cluster headache, paroxysmal hemicrania, and SUNCT. And the way I remember it is actually the headaches, they are a bit longer when it comes to cluster, and then proximal hemicrania, the attacks are a bit shorter, and then in SUNCT and SUNA, they are even shorter than this. So if you can see in cluster headache, it can last from 15 minutes to about 3 hours. In proximal hemicrania, it's up to about 30 minutes, and you can see it's about 10 minutes in SUNCT SUNA. And again, you need only about 5 attacks for cluster. You need about 20 attacks for proximal hemicrania, and 20 of these for SUNCT SUNA. And the other thing is actually you need about 1 every other day, or 8 per day. The 8 per day is because if you have 3-hour attacks, that's 24 hours a day. So that's why the 8 per day there in cluster headaches. So you can actually have very frequent attacks of cluster headaches in a day. And for proximal hemicrania, you need more than 5 attacks per day. But on the other hand, for SUNCT SUNA, you can at least, you need to have at least 1 attack a day. In all of these, the autonomic features are there. So basically, you can think of these conditions as a kind of a slope there, where cluster headache, proximal hemicrania, and then your SUNCT SUNA. So what does cause cluster headaches? Okay, when twin studies show that cluster headaches can happen more often in twins, and you also know that there is a higher degree of first-degree history in children. There is a good study which looks at all the parents of adults who've had cluster headaches, and the prevalence in those population, in the adult population, the parents, is actually about 1 to 8%, which is much more than in the community. So all of this gives us credence that it's actually there is a genetic element to it, probably. The anatomy we know is a trigeminal-vascular system. From animal studies and by imaging studies, we know which pathways are being activated here. And again, PET studies show very clearly that the posterior hypothalamus, the suprachiasmatic nucleus is involved. I'm sure if you have been on the cluster headache lecture before, the pathophysiology was covered there. So I won't go into very much detail. So what's been our experience? I think we looked at our data. We identified about 9 patients over a period of about 7 years. So it's about 2% of our referrals. So I see about 200 new patients a year. Which means about 4 cluster patients probably a year. And among them, equal distribution between men, women. The presentation, the child, when the headache started, on average is about 10 years and 11 months. The youngest age which we had in our group was about 6 years and 5 months. Of the 9, 2 had chronic cluster headache and 7 had episodic. And 3 of the children had multiple headache. They had and they all had basically migraine and cluster headache. And 5 had a family history of headaches, but only one of these had a cluster headache in the first degree relative. Now, you might ask, how did you diagnose cluster headache without autonomic symptoms? I'll come to that. Of the 9 patients, 7 experienced autonomic symptoms, and all of them had agitation as a cardinal feature. About 7 of them had photo and phonophobia, and other important feature which I want you to take note is actually none of them, the pain was affected by movement. And this is crucial. This is a very important phenotypic distinguishing feature between your migraine and cluster headache. In a migraine, a child with migraine doesn't want to move, because one of the diagnostic thing about migraine is actually you move, the pain actually gets worse. So you want to rest and stay still. On the other hand, a child with a cluster headache is severely agitated and they are pacing and they are moving. And if you are able to, I'll show you some videos later on, and you can basically diagnose these attacks on video just looking at them, because their phenotype is just different. So in our cohort, these attacks lasted around about an hour, each attacks. The frequency was up to about 10 per day on average. And none of them were sensitive to indomethacin. And we say that because we know that of the 2 headaches that I told you about, the cluster headache and the paroxysmal hemicrania, the paroxysmal hemicrania is an indomethacin sensitive headache. And as you might have read in the criteria, it's one of the criteria that you would actually say to diagnose paroxysmal hemicrania. All headaches were described as severe or very severe, and the children described them. You remember we said about drilling or boring, but they used terms like sharp, stabbing. There was throbbing and there was pounding as well in the description. The location was always unilateral, but they also said it was frontal, orbital, and periorbital in locality. They all had normal neuroimaging, and it's again one of the perks. You sit in a tertiary center, they all come with scans. And in one of them actually did have a tumor, which was a dermoid, which was removed. But and again, 3 of them had normal pituitary test. And the reason why it's there is that there was a series which was published from Queen's Square, which sits next door to us, and the adult patients, a lot of them had actually pituitary tumors, and they all had cluster headaches. So the association is a bit tenuous. We have now screened all our patients with cluster headaches, and we haven't actually found anything at all. And again, they all seem to have normal pituitary tests. The only endocrine abnormality we know that happens is actually in adults who've had cluster headaches, and they've checked during an attack, they do have a lower testosterone levels. And normal neurological examination, all except for perhaps occipital nerve tenderness, which you can see in some migraines as well. And as you can see, 3 of the other children actually did have migraine as well. So unfortunately, by the time the children came to my clinic, about 2 years on average, they tried anything from about 5 to about 19 different medications, basically the whole BNF thrown at them, I think. No treatment was consistently effective in all our patients, but we did find that sumatriptan, nerve blocks, which Ishaq showed you earlier, we had used prednisolone in one, melatonin was effective, diclofenac, flunarizine, oxygen, surprisingly, was effective in only one, verapamil, topiramate, pisotifen, and dihydroergotamine. So you might ask, what's different in these attacks from migraine? They are relatively short. So as you know, migraine attacks usually last up to about 4 hours. In children, it can be up to about 2 hours or less, but usually, by the time, if you include sleep in the attack, it's about 4 hours or longer. But these TAZs are shorter. They usually are, an hour and a half, not more than that. Usually shorter attacks. Incredibly side-locked, like I said before, and ipsilateral autonomic features. Now, you can get autonomic features in migraine, but they usually are bilateral that I've seen in children. Very rare, but it happens. But the cardinal feature is its agitation and restlessness. Okay. Now, there are other short primary headache disorders that I mentioned here, but none of them will have the phenotype that you will have in terms of cluster headache. So, what do you do if you do suspect a child with a trigeminal autonomic cephalalgia? As Ishaq pointed out, the one is actually identifying the headache. So history, a good history, and if you have a video, ask them to video an attack. That can go a long way in phenotyping the headache. Management is always multimodal, emotional, psychological support important. You need to be able to talk into school and find out what the attainment is, and how you can actually make a school plan. And if you're going to prescribe things like oxygen, you will need to make sure that a proper school plan is written up. What I see in a lot of these children, which I hadn't put in my audit finding, is actually there are coexistent conditions you need to look out for, and these include ADHD, a pervasive developmental disorder like autism or autistic spectrum disorder, anxiety, depression, much more common in this population, self-harm, and gender identity disorder. And we've seen all of these gamut in this group. And a simple thing to do if you're not sure is actually to give an indomethacin trial. Give indomethacin 25 milligram 3 times a day with a good stomach protector with a PPI, and do a 3-week trial, start off with a small dose and increase it. And if the headache stops, because it's an all or none phenomena, if you have proximal hemicrania, then this is not a proximal hemicrania. It could actually be cluster headache. And cluster headache treatment, as an adult, you give 100% 12 liters of oxygen, and then subcutaneous sumatriptan, which is recommended in children. We tend to use intranasal sumatriptan. In terms of prevention, I've started using melatonin more. It has actually been quite successful. Topiramate is another drug. Verapamil we've used in one, but actually in the majority, I've managed it with melatonin, topiramate, and nerve blocks. So again, a short kind of summary as to how the proximal hemicrania and the cluster headache, which are the TACs, you can distinguish with migraine. And the main thing is actually a migraine child is still a child with a cluster headache especially is very restless. And the cluster headache and paroxysmal hemicrania, you give indomethacin. If it gets better, it's paroxysmal hemicrania. If it doesn't, it's cluster headache. And of course, indomethacin might take the pain away from migraine, but it doesn't help like it would in paroxysmal hemicrania in stopping the attacks. Okay, I'm going to stop here. thank you for having me. If, as Ishaq says, you do have children who do want to be in those trials, please do refer them. And that's my email address for you. Thank you.
Oh, thank you very much, Prab. That was a very good talk. I've got lots of questions, particularly for the autonomic cephalalgia in children. Let's start with Kay. I sometimes think with adolescents that it's the parents who need more treatment than the child does. How do you address the issue of parents stressing to have a scan done in children?
Yeah, that's a really good question. I think, yeah, when you're doing a headache consultation with an adolescent, there's usually two really anxious people in the room. And you're quite right, the parents are the most anxious. The doctor's probably the second most anxious. And the child's probably less bothered than most of the others. I think it's really important to try and talk to the child by themselves if you can. Because sometimes there are things that the child is anxious about, things that are going on at home that are causing the migraine to be particularly troublesome. So I do try and speak to the child by themselves. And then I bring the parents back in so that we can make a management plan together, because the parents, as you say, are anxious and they do need to be fully involved in the plan. And usually I handle it by printing off material, particularly the RCGP guide, and asking the parent to sort of read through that with their child and speak to school about it. And then coming back to see me, I think we do have short consultations in primary care, but we have a huge advantage that we get to see our patients again, and we can see them more quickly again than you can in secondary and tertiary care. So bringing them back, and then if sometimes, it's just a bit of education they need, but sometimes you need to be a little bit more intensive and help them make a migraine management plan.
Okay. Ishaq, what do you do? I mean, how do you put them off doing imaging?
Yeah, I think it's very important. And quite often they come with a hidden agenda. They don't say it clearly that they are anxious or they are worried about brain tumor, but they keep asking you questions. But I think if you open to them the opportunity to speak, what worries them and why are they coming, and what is their worst worst scenario, they will tell you that they are worried about brain tumor. They were worried about, they know somebody who had brain tumor. They know about somebody who has been seeing doctors for a while and then he had serious disease. And I will share with them, I will say, yeah, that's right. That's always worry us. And that always, and the reason we are asking you all these questions is because we want to identify any reason to make us worried. And all the answer you have given to me and the examination which I have done are reassuring. And if you explain to them why you are not considering tumor as a problem and why investigations are not necessary, most of them will accept that. However, there are always some who will say, I'm still not reassured. And in this situation, I think it would be easier to do a scan rather than to keep postponing it. And we know that sometimes to diffuse the situation, it might be better to do an MRI scan. But in the vast majority of families, and when you explain to them why you felt that a scan is not necessary, they usually accept. And so it's just education and communication, really.
Yeah, perhaps you have the advantage that you are such a rare breed that if you reassure them without doing a scan, they can't go anywhere. With us, in the adults one, if you don't do a scan, they go to another neurologist. So,
yeah.
So I think that's the advantage you have got. Let's take the questions from the audience first. I think Prab, you were about to answer that extrapyramidal problems with metoclopramide?
Yes, I was just saying that actually we hardly see them except when we use metoclopramide intravenously, or they have been given at a higher dose, or they have been used frequently. So in a smaller dose, usually for episodic migraine, the side effects, they can happen, but it's actually extremely rare. The other thing to say is actually, one of the questions will be, what is it we are treating when we give the acute treatments? The acute treatment is actually, for pain, or is it for nausea? Is it for the vomiting? What is the most bothersome symptom for the child? I think that will be a very useful question to ask in any consultation, because what we think is the most bothersome might not actually always be the one which is actually most bothering the child. I say this because in my clinic, we actually have more than one type of headache. So we know that, for example, with migraineurs, they can actually have a primary stabbing headache coexistent. And I have teenagers who will come to my clinic and say, well, actually, I'm not worried about my migraines, but the primary stabbing headaches are the ones which are most worrisome, which is what I want treatment for. So I think exploring which are the most troublesome, because again, what is the most bothersome symptom for the child versus the parent? Because there are some symptoms where the parents actually just looking at the symptoms, that's actually more worrying and frightening. But actually for the child, it might actually not be, because from children, vomiting, sometimes they might say actually they feel better after they have actually vomited. They will actually have a headache, they will actually vomit, they will go to sleep, and they will wake up and they are symptom free. So I think one of the tips might actually be to just concentrate on what the most bothersome symptom is in terms of giving a symptomatic management.
Great. There was another question about infantile torticollis, which was mentioned. I think the question was whether infantile torticollis or childhood torticollis, would you not refer the patient first to a pediatric neurologist for EEG, excluding a seizure? So in primary care, Kay, have you come across any, and what would you recommend to your colleagues to refer them to secondary care?
Yeah, I mean, it's pretty rare. I hadn't personally come across it. So I would be referring up to secondary care. I'd write a good referral letter, I hope, outlining what I thought it was, to ensure the child wasn't over investigated. But I don't think I'd be able to get out of referring that child.
Okay, so the other two, Ishaq and Prab, you agree that if there is an infantile torticollis, then it needs investigation, basically.
I agree. I think in the first instance, I think a general pediatric review will be important here, especially if it's an infant. And I think it's been noted first. I think there are a few things, especially a early onset of hydrocephalus or something like that can present with a torticollis. Now, the commonest reason would actually be a benign proximal torticollis, but I think there are some other conditions which might not be able to rule out in a primary care setting. So assessing an infant in terms of the fontanelle and the rest of it are actually important. The other commonest cause will actually be a sternomastoid tumor, for example, again, a benign condition which might actually just need a bit of physiotherapy. There could be a positional element to it. So all of these things will need a pediatric review. Now, the thing about the wonderful thing about the benign proximal torticollis is actually it's episodic, and you know that it actually just not happens on one side; it can actually happen on the other side. And during an attack, the child is actually completely well. Okay, the child is actually not distressed, nothing. It's actually not in pain. So it's a condition which you can, the child has got a tilt to the neck, but otherwise is completely well. And in between is again completely well. No other symptomatology. And it actually keeps happening. And there are children where you can actually be persistent, the torticollis, in benign proximal torticollis. And as Ishaq has mentioned, there might be a genetic component to it, especially the CACNA1A mutations, and recently PRRT2 has also been described. But in the majority, reassurance is all is needed. There's been some good work by a colleague, Amy Gelfland, where people have actually now cottoned on to the fact there is some evidence that actually, if you spend a lot of time tilting to one side and it's persistent, then the motor development in terms of the child can actually be a little bit delayed. So you might actually see that the child achieving milestones a little bit later than they would normally, if they, especially the torticollis, is actually a bit prolonged attacks. So there is some interesting thoughts going on whether we should actually be actively treating these episodes of torticollis. And Ishaq just mentioned, Ishaq and Amy wrote a review on Neurology Nature Reviews about this early childhood migraine variants and childhood migraine syndromes. And I think it's an exciting area to look out for in the future, really, for both research and understanding migraine itself.
Yeah, I think you've quite nicely answered the question. Ishaq, shall I come to you with a question from Louise Rusk in Belfast? What is the best management for cyclical vomiting syndrome?
Yes, this is a very interesting question. And I've been asked this question several times. There is unfortunately no satisfactory treatment yet, but there are lots of things one can do to reduce the suffering of the child. First, as an acute treatment, it is very important to try to treat as early as possible after the onset of the attack, when the child is still nauseated, before the child starts to have a vomit. And sometimes some parents can predict when the attack is coming. And as I said, they can pinpoint it to within 2 to 3 days. And sometimes a targeted treatment at that period of time can prevent evolvement of an attack, or you can abort an attack. What we do usually is, at the first symptom or the first sign of an attack is coming, you can give ondansetron, and it can be given as a melt tablet, and it can be given as early as I said, as early as possible, and try to rehydrate the child, try to give as frequent small amount of fluids, usually by mouth, and try to prevent dehydration. That can happen, can work in some children. Some of them you might need to give parenteral treatment with ondansetron to prevent the excessive vomiting and the dehydration. The treatment for prevention is probably more important if that child is having frequent episodes or prolonged episodes. Anti-migraine prophylactic treatment have been used, and the most success comes from amitriptyline. And amitriptyline given on a regular basis, a dose about 1/4 milligram per kilo up to 1 milligram per kilo per day might be effective, and it has been shown in open studies I have to say, in reducing the number of attacks and reducing the severity of the attacks or the length of the attacks. Other preventative treatment, including Pizotovin has been used, topiramate has been used, propranolol for not that much impressive results, but some people used prokinetic drugs such as erythromycin, which in an open study has been shown to reduce the migraine, the cyclical vomiting attacks. So there is two parts of the treatment: one, to treat the attacks when they happen and treat them effectively by reducing and stopping the vomiting and preventing dehydration, and then for prevention. And sometimes, as I said, targeted prevention can be useful. Some patients, they have the attacks are so predictable. Every 6 to 8 weeks, they get an attack. So the parents know that on 12th of October or around that day, they're going to have an attack. So 10th of October, or 2 days before, they give a course of amitriptyline or a course of ondansetron. And it has been successful in some, not in all, but in some. And that's another strategy one can use.
Thank you very much, Ishaq. Prab, there is an interesting question from Brazil about, do you see seasonal variation or seasonal occurrence of cluster headache in adolescents as well?
Renato, yes, I think we do. It's an interesting question. There is definitely a circadian rhythm to it. I think usually, like in adults, we see them, most of them in the evening or night. And again, it's migraine can also occur any time of the day. In fact, most of the time, the children waking up from sleep might actually be one of the red flags that people might see. But I think if you count all the nighttime headaches, migraine probably will still be the commonest headache in those population as well. But we do see that seasonal variation in terms of happening around June attacks. I think we've definitely had patients where they will have episodic attacks around that time.
Yeah, I would like to share a very good anecdote from one of my patients that I saw when he was about 20, 21 years old. And he was never diagnosed as cluster headache. And the mom said that when he was little, every year he started to get the headaches in September. And she attributed that to the opening of the schools. So he tried to avoid going to school. That's why every time the schools open, he would have the attack. And once he's for a couple of weeks and he sets in the school, it goes away. And I usually put it in one of my cases. It was really, really interesting. And for 7 years, it was not given a diagnosis. So that's very good. While we're staying for cluster headache, I'll ask you first and then come to Kay about it. How do you address licensing for cluster headache prophylaxis in adolescents? Because none of them are actually licensed for them. How do you address that? And then I'll come to Kay. How do you convince your GP colleagues to listen to a neurologist or a pediatric neurologist or a pediatric migrainologist and prescribe non-licensed medication? So Prab starts from you first.
So I think it's a tricky one. I think I can see how difficult it can be for general practitioners. In addition to general practitioner friends, I'm married to a general practitioner, so I know how difficult these things can be for GPs. So I think we again are in a privileged position. I think we do see these rare headache disorders, so I would expect my GP and pediatric colleagues to be referring these children with these rare conditions to a tertiary center. And literally, we have to take ownership of the prescribing and monitoring. And we have had some shared care guidelines for these medications. So for Rapamil, or for that matter, melatonin or whatever. And there are some areas where the CCGs will allow GPs to prescribe it, but I think increasingly CCGs are very strict in what they will allow the GPs to prescribe. So I think within reason, there are some GP colleagues who would, if I see the child regularly and ask for repeat prescriptions from the GPs, they would do that. But for others, it has to come from a tertiary, which can be very, very difficult for some.
Yeah, so Kay, just mentioning that amitriptyline recommended by NICE but not licensed, right? And I often get it, you prescribe it, because I'm not prescribing because it is not licensed. So a broader issue, how would you convince your GP colleagues that this is something that they should allow and start prescribing, even if it is not licensed?
Yeah, it can be difficult, and it is. I think Dr. Prabhakar has really sort of explained that clearly. You know, so, some GPs and some primary care trusts can allow it, and others can't. I'm really fortunate that I work in an area where generally we are allowed to prescribe if it's recommended by secondary care. So we don't run into too many problems. I haven't personally had problems myself with children's prescribing. I had an adult who I wanted to prescribe candesartan for. Again, that's unlicensed. The GP queried it, and they were happy to just sort of prescribe it once I'd pointed them into the sort of sign guidance. So it's variable. I mean, I think the key is we've got to remember that the child and their family are at the centre of all this. And as a team of doctors, sort of in primary, secondary and tertiary care, if we can coordinate things so that the family aren't having to dash around the country collecting prescriptions from odd places, and then I think that's really important. So that's what we need to be trying to aim for, really.
So Ishaq, you are in a privileged position being in Scotland, that candesartan is being recommended by SNC or the sign guidelines. But we have a problem in the, here the NICE does not recommend candesartan. Now, do you have any experience of candesartan in children?
No, my adult colleagues, they use it quite a lot in adults over the age of 18. We have not yet started using it in children, simply because there is nothing in the literature to look at its safety or its efficacy in pediatric migraine. And that would be something, I suppose, a research project for someone, I suppose.
Yeah, the other question, which I'm being a devil's advocate, people coming at the age of 17, or say late 16 or early 17, or maybe even late 17, and you say, oh, this is not licensed this is only licensed in adults, particularly Botox. What is the difference in the biological age of a 17 and an 18-year-old? I mean,
yeah.
How do you address that issue?
Yeah, I think very important to realize that in pediatrics, 1 in 3 of all the drugs which we use in all indications, in all subspecialties of pediatrics, are either off license or off label. So we are used to it. We don't have any problems in using drugs off license or off label, as long as we have good reason to be reassured or reassuring ourselves of its safety and its efficacy. And for Botox, it's probably by the age of 15, 16, children will behave or are behaving in a very, very similar way physiologically and probably anatomically, like in adults. Our problems is needle phobia in quite a lot of kids. And quite often they wanted the treatment, they don't want the injections. And quite often we need to include our psychology and play therapists to help them in managing it. And once they have managed it, they will be all right. Our managers are not very much fussed about the license because they know that in pediatrics, we always use drugs off license. I mean, it's not an issue, as long as we reassure them, as long as we can demonstrate that it is efficacious and it is safe.
Well, I mean, I used Botox in a 17-year-old and I had a backlash from the CCG that why didn't you apply for an individual funding request? Why did you give Botox? It's not licensed for less than 18.
That's the beauty of Scotland. We don't have CCGs.
That's correct. Coming back to Prab, melatonin, what dose you use in children?
Yeah, I was just going to pick up on the candesartan. I have used in that in teenagers, and in fact, interestingly, GPs were actually quite okay prescribing candesartan compared to the other drugs because they're used to prescribing candesartan, I think. So in some of the teenagers where I have prescribed candesartan, I haven't had a problem, which is interesting. In terms of Botox, I agree. I think a lot of it is about the needle phobia. Having said that, I think a lot of the occipital nerve blocks that I do, we've done it in, we don't use any anesthesia. We've done it in children as young as 8, and they've come for repeat injections as well. So I think explaining the procedure and things and reassuring them usually does help. The main problem I find is actually about the funding for the drug, and in terms of something without license, because it's more expensive. And in our center, I find the efficacy for the nerve blocks is probably as good as some of the outcomes from the Botox. So we haven't actually got a Botox program. We actually have a nerve block program. And the same thing for DHE, for example, again, unlicensed, but we do use it for infusions in intractable migraine. In terms of melatonin, we've used doses up to about 9 milligrams actually in teenagers. So we start off with a sustained release capsule, which comes as a 3 milligram one. The fast acting comes as 2 milligrams. So we've used up to about 9 milligrams.
There was another question about alpha blockers. I never heard of being used in migraine. Any of you have any experience or publication? I think I know you answered this out, that there is no publication as such.
Yeah, I'm not aware of its use in children.
The other thing, Prab, you mentioned about that in your experience of the cluster in the younger people, the duration, the number of attacks could be as high as 60. How would you then differentiate between the other short-lasting ones?
Yeah, so I think it can be very difficult. The other thing I said was in the talk was that some of them actually didn't have autonomic features, but in those, what I do find in terms of when you follow them up longitudinally, is actually the agitation and the unilaterality of the attacks come first. The autonomic features in some patients do not come early enough. They will come a bit later. And in fact, for the younger age group, it's very rare to have the textbook TACs. They will actually emerge over time. And I suspect part of it is to do with the biology and the brain development. So I think in the younger ones, especially, they can have shorter attacks. They can actually just be restless. The only thing that you will find is actually the unilaterality of it, with the side locking and the agitation, the incredible agitation. That's all you can go for. And all the rest, you follow them up enough, it becomes evident as they grow a bit older.
Great. Now, just one thing that I wanted to tell the audience, and I always say in my talk, as the duration of the headache gets shorter, the name gets longer. And so therefore, if you hear something longer, that will be really very, very, very short. So that was very interesting. So guys, ladies, thank you very much. Kay, once again, you've been excellent. And Ishaq, it's nice to see you, and Prab as well. We hope to meet face-to-face soon again. I'm really glad that you made the time to be a panelist in the webinar. So thank you very much again, and thanks very much for all the audience that has have attended. So look forward to seeing you sometime in future. So do you want to really show the video, or because I can stop recording and play?
Yeah, quite happy to if
let me just stop the recording.